Hey everyone, it's Sarah with RegisteredNurseRN.com, and in this video I want to be going over myocardial infarction. This video is part 1 of a part 2 series, and what I'm going to be covering is the patho, the complications, the signs and symptoms, and how it's diagnosed. And in part 2, I'm going to be covering the nursing interventions and the medications used to treat MI. And as always, over here on the side or in the description below, you can access the quiz, the notes, and the other videos that are in the cardiovascular NCLEX review. So let's get started. First, let's start out talking about what is the definition of a myocardial infarction, also referred to sometimes as an MI or a heart attack. It is where there has been limited blood supply to the myocardial tissue that causes it to die or become necrotic or necrose. And some causes of this, what causes it? The most common cause is blockage in a coronary artery due to coronary artery disease. And we talked about this in depth in the NCLEX review about CAD. And if you want to watch that, a card should be popping up so you can access that. Another cause is a coronary spasm, and this can be from drug use like cocaine, or the patient has uncontrolled hypertension. And what happens with this is that the coronary artery spasms, it constricts, so these little arteries on the heart, and what happens is when you have that constriction, you have no blood supply going to that heart muscle. So that muscle is deprived of all that rich oxygenated blood and it starts to die. Another cause is damage to the artery due to a coronary artery dissection. And what this is that you have your artery, it's made up of different layers, and there is a tear in the inner layer of the artery, the tunica intima. And what happens is you have this tear and blood starts to leak. And it leaks into the tunica media, and this causes, think of it like a little bulge, and it limits the size of the lumen of the artery. So whenever you have that, you have constricted blood flow, restricted blood flow going to that heart muscle. And this can happen in young women who are young and active, it's the most common type, and it happens spontaneously. Now, let's look at the anatomy and the pathophysiology of how this happens. I'm going to walk you through a little bit later of what happens minute, hour, days, and see what happens and how this heart tissue is dying. Okay, so first, let's go over the anatomy of the coronary arteries. In this drawing here, you will see the right coronary artery and the left coronary artery. And these two coronary arteries branch off from the aorta, which has just received rich oxygenated blood from the lungs. And the job of these coronary arteries is to supply the heart muscle with fresh blood so it can work appropriately. And notice it sets right on top of the tissue. Now in this drawing, I wanted you to see where each coronary artery sets in relation to the atriums and the septum and the ventricles, because if you get blockages in these specific arteries, it's going to cause problems to either the left atrium, the ventricle, or the septum, and you're going to have damage there because you're going to get necrotic tissue. So whenever you're learning this, it's really important you remember which artery supplies what. So let's go over that real fast. Okay, your right coronary artery comes right off through here, and notice where this whole right coronary artery is setting. It branches off into these little branches, which we'll talk about here in a second, but it supplies your right atrium and your right ventricle. Here is your right atrium and here is your right ventricle. Next, you will have the right marginal artery, and this supplies your right ventricle and your septum, and you see it right here. It's branching off. Here's your right ventricle and your septum. Then we have our left coronary artery. And over on the other side of the heart, because this right here is our anterior view, the left coronary artery comes out. And that's why you see it outline, these two right here, the posterior descending, because these are on the other side of the heart, but I wanted you to be able to see them in this view. And the left coronary artery, as we said, supplies the left side of the heart, but it branches off into little areas. And it branches off, we have the left circumflex artery. Circum means around. So this artery actually comes around the heart in this area. And notice where it sets. It supplies the left atrium and the left ventricle. Then you have the LAD, the left anterior descending artery. Comes down through here, and this supplies a lot of areas of the heart. It supplies the right ventricle, the left ventricle, notice how it's branching out over here, and your septum. Now, let's remember some things about the LAD. The LAD is the most common site of blockages in patients, and blockages in your left coronary artery, especially the LAD, can cause the worst damage from a myocardial infarction because of the damage to the anterior wall of the heart, which we'll be going over the different anterior lateral parts of the heart a little bit later when we talk about EKGs. And why? Why does it do this? Well, in heart failure, we learned that our left ventricle is the biggest area for pumping action to get our pumping, to pump our blood. So if it gets affected, you have an anterior wall MI, your LAD causes a lot of damage here. You will get left ventricular failure over here. So that, whenever this happens, you get a lot of damage in the heart whenever you have a blockage, especially in your LAD, and if it happens before where a branch happens. Quickly, let's review how a coronary artery can actually become blocked. Now remember, coronary artery disease is the #1 cause of why you have a blocked artery. Also, you can have coronary spasm or dissection of the artery. But let's look at how it builds up over time with coronary artery disease. So here you have a healthy coronary artery. You have blood flowing through it, and you have a little bit of LDL, which is your bad cholesterol. Now, over time, this happens. What happens is that maybe the patient has risk factors, such as they're a smoker, which has caused damage to this artery, or they have high cholesterol, or they have uncontrolled hypertension. What happens is that this artery becomes damaged. When it becomes damaged, your LDL likes to stick into this artery wall. And over time, it grows, as you can see here. Whenever it grows, it limits blood supply. Now, some of these plaques, it's turned into a plaque, can rupture, vulnerable plaques. And whenever it ruptures, as you see here, it spills its contents into the blood, but the body sees that, hey, we have damage to our artery wall. We've got to fix it. So the body thinks it's helping, but in reality, it's going to cause some major problems. So it sends all those platelets there to go and to fix that artery wall. So they come and they aggregate, which is represented in this blue area right here. And what happens? It thought it was fixing the artery wall, but it actually completely stopped blood flow to that heart muscle, those heart cells. And those cells die quickly. And when this happens, myocardial infarction happens, and you start getting the following complications. When the muscle is 100% blocked, there's no nutrients going to those cells will die. And it is irreversible after approximately 30 minutes. So as the saying goes, time is muscle. We've got to get in there fast as healthcare providers, try to save as many of these heart cells we can to prevent as much damage as possible. And when these cells die, they cannot be replaced. They are gone forever. Now, early signs, let's talk about this. Whenever there's a blockage, those heart cells start to die. There are no physical changes to the heart yet until about 6 to 8 hours. However, when those myocytes die, they start to release some things that lets us know whenever we go in and draw blood that, hey, there's been injury to the heart. I'll talk a lot about this whenever we're going over the diagnosing part, but I'm just going to hit on the highlights. Okay, so whenever these myocytes die, myoglobin is released 1 hour post-injury. It's an early marker. However, it's not too specific though. We like to look at troponin levels. This is one of the gold standards that we look at in the healthcare field. They're drawn in sets, usually every 6 hours times 3, depends on how the physician orders them. And it is released 2 to 4 hours post-injury. Another thing is CKMB, and it is released 4 to 6 hours after injury. Now, you will also start to see EKG changes early on, which we'll talk a little bit later about, like ST segment elevation or depression, T-wave inversion, or it's hyperacute. Now, later on, about 24 hours to 36 hours later, inflammation starts to set in, and neutrophils come onto the scene at the site of injury where that damage tissue is, the neutrophils start to come. However, even though they're coming there to do their job, it can cause complication. The patient is definitely at risk for pericarditis. Talked about this in an NCLEX review. This is where all of a sudden your patient might start complaining of pain whenever they're coughing or lying down on their back. It's relieved when they're leaning forward. And on auscultation of the heart sounds, you may hear a harsh grating sandpaper noise called a pericardial friction rub. And this is one of the signs and symptoms of pericarditis. Also, the patient is at huge risk for going into cardiogenic shock. Got some pump failure going on. And also, a lot of times in patients who've had a myocardial infarction, you are going to see arrhythmias, like atrial and ventricular arrhythmias and AV blocks. Then 10 days afterwards, at that site of injury, the tissue will start to experience granulation due to the macrophages coming on the scene. And what are these? They are white blood cells that come to clean up the dead cells. However, whenever they come on the scene, just like neutrophils, they're going to cause, they increase the chances of complication. The complication they increase is because whenever they're coming in to clean up that site, they cause the tissue to become weak and unstable. So there's a risk of cardiac rupture. Then within 2 months, there is scarring, the last phase of healing. You will have scarring, which will affect the size of the heart and the function due to the increased collagen. And other complications that a patient may have after an MI are heart failure, depression, or ventricular aneurysm. So what are the typical signs and symptoms of a myocardial infarction that you need to be watching out as the nurse? Okay, to help us remember, let's remember the mnemonic crushing. Why crushing? Because a lot of times whenever patients are having an MI, they will say it's like crushing chest pain. That's one of the big things that pop out at you. So remember crushing. Okay, so C for chest pain. This chest pain will be described as intense and heavy, very severe. R for radiating chest pain. This chest pain will not only be heavy and intense, but it will radiate to the left arm, the jaw, or the back. That's a telltale sign if they tell you it's radiating. U, the chest pain is unrelieved by nitroglycerin or resting. S, sweating. It will be a cold sweat. H for hard to breathe, have shortness of breath just because of the intensity of the pain, literally taking their breath away. I for they may have an increased heart rate or blood pressure, which is going to make the chest pain even more intense, or an irregular heart rate. N for nausea and vomiting. And G, they are going to be absolutely anxious and scared. And as a nurse with patients who have actually experienced this in front of me, I can tell you that I have seen this and that this is really real and it really happens. Now, some things you need to take into consideration, women. Women, for some reason, present a little bit differently with chest pain or their signs and symptoms of myocardial infarction. So if you are educating patients, the signs and symptoms, take this into consideration because some women may not have that typical heaviness on their chest, but they feel short of breath, they have pain in the lower part of their chest, and they feel really extremely fatigued. And they'll just play it off like, I think I have an illness like a flu. I've had women patients who actually thought they came in, they were having a myocardial infarction, and it turns out that they thought that they had the flu. So they had put off coming in because they just thought they were sick. So educate women that this could be a sign. Also, patients who are diabetic, a silent MI. This is where they don't have any pain at all. They just don't feel good, comes in, their EKG shows that they've had one, and the reason is due to diabetic neuropathy, where those nerves have been damaged that feel pain in the heart. So they had a heart attack, but they didn't feel it because those nerves that would pick up that pain normally are damaged. Now let's look at the diagnostic tools used to diagnose a myocardial infarction that may be ordered by the physician. As a nurse, your role will be collecting these, for instance, the cardiac markers, or educating a patient about them, or just knowing what to expect whenever a patient does have an MI. So let's review these. Okay, cardiac markers. As we talked about in the patho part, those myocytes release these markers that helps us to determine, hey, there's been injury from a possible myocardial infarction. So the first thing let's talk about are troponins. This is the most regarded as of right now in the hospital setting in detecting a myocardial infarction along with an EKG. This is a protein released from the heart muscle when injured from an MI. They are typically drawn in a series. A lot of physicians order them every 6 hours times 3 sets. It can vary depending on your physician's preference. So your job as a nurse, it's very important you know when the first troponin level was drawn and make sure that those next levels get drawn. And you're going to be watching those lab results come into your computer system and monitor them if they're elevating. If they are elevating, you need to notify the doctor immediately so they can order whatever needs to be done to further evaluate this. Next is myoglobin. This is released from the myocytes again. It is an early marker used for early detection, but one thing with this is that it's not very specific to the heart, so you need further tests to evaluate it. And it's released 1 hour after injury. It's one out of all the markers, it's one that's released the earliest. Next, CK. This is another test that may be ordered, and it's a protein which is released whenever there is muscle damage. However, it's not just specific to the cardiac. It could represent skeletal muscle as well. So the physician will need to order to further evaluate it to see if it is heart specific, the CKMB. And this elevates 4 to 6 hours after injury. But again, most regarded are troponin levels, but you will probably see these ordered as well as cardiac enzymes. Okay, other tools that may be ordered by the physician that you just need to know and be familiar with as the nurse is an echocardiogram. What is this? This is an ultrasound of the heart to see if there's any damage to the heart muscle. Another thing, a heart cath. This is where they go in, either in the femoral artery or the radial, depending on the physician, and they inject a dye into the coronary arteries. And this dye, after they inject it, they take an x-ray and they look in these arteries to see if there's any blockages. If there are blockages, where are they located? Is there any damage that's been done to the heart? And can they possibly put a stent in there and open up that artery to start replenishing that heart muscle with some more blood? Another thing that may be ordered is a stress test with myocardial perfusion imaging, also called MPI. This assesses the heart's response to exercise. They can do it with a chemical or on a treadmill, and they take imaging after they do that, and it evaluates the heart muscle, how that blood flow is getting to the heart muscle with imaging. Another tool ordered is an EKG. Anytime a patient is having chest pain, comes into the ER, they're going to get an EKG. So you need to be really familiar with this as the nurse. A lot of hospitals are set up where there's a physician protocol. If the patient, anytime they're having chest pain, you obtain an EKG. Either you will obtain it, your EKG tech if you have one, or a nursing assistant that has been trained in this. So what you will be doing after you obtain it is that you're going to look at the EKG and you are going to assess for any changes. If you see any changes, you need to notify the physician immediately. And what's really important is that you compare your EKG that you just got to previous EKGs the patient has had in their chart and telemetry strips. And you want to know what areas of the EKG reflect certain areas of the heart and how to read it. So let me go over that with you real fast. Here is a drawing of a basic 12-lead EKG. And each of these little areas represent different views of the heart. And as a nurse, what you're going to be doing is you're going to be looking in these specific areas for any EKG changes. What you're specifically looking for is any ST segment, elevation, or depression. You're going to be looking at your T waves. Are they hyperacute? Are they inverted? And you're going to be looking for any pathological Q waves as well. So real fast, let's go over what each part of this EKG represents, which view of the heart it's looking at, and what coronary arteries are probably being affected if you've seen changes in that area. Okay, the lateral view is represented in the purple. This is seen in lead 1, AVL, V5, and V6. And the lateral view of your heart right here on this diagram is about right here. Now, if you notice from where we covered it in the beginning, what's in this lateral view? What area of the heart is being fed by what coronary arteries are feeding the lateral part of the heart? Your circumflex and your LAD, your left anterior descending. So if you're seeing EKG changes, V5, V6, AVL, and lead 1 probably may have a blockage in your circumflex and your left anterior descending. Now inferior, this is represented in lead 2, lead 3, and AVF. This is represented in the green. The inferior part of your heart is about in this area right here. And if you're seeing EKG changes in these areas right here in the green, you may have a blockage somewhere throughout your right coronary artery. Now septal, this is represented in V1 and V2. And it's where your interventricular septum is located. And notice, what is feeding this area of the heart, your septal area? Mainly your LAD, your left anterior descending. So if you're seeing changes there, probably have a blockage there. Anterior view of your heart is represented with V3 and V4. And this is about right here in this area. And that again is supplied by your LAD, your left anterior descending, and it's represented in those 2 areas right there. And just again to recap, remember whenever I was talking about if you have damage in your LAD, you're going to have a lot of damage on this your anterior side and in your heart. And notice where a lot of your LAD is feeding your heart muscle at. Now let's look at the specific EKG changes that you were looking for as the nurse. First, let's go over what a basic PQRST complex should look like. Okay, first you have this red line. This is your isoelectric line. Certain things should fall above and certain things should fall a little bit below. And that's the big thing you're looking for whenever you're looking for these elevations and depressions. So here, this little bump, you have a P wave. Then you have just a little smidge of a dip, which is your Q. And then you have a tall R wave, then a small little dip S. Then you have your ST segment. This extends from S to T. So that right here, this is the big part we are looking for whenever we're looking for changes. So notice it's nice and flat. It's on the isoelectric line. And then you have a little bump of a T wave. It's nice and rounded, not too tall. It's not flipped. So that's perfect. We like that. Now, ST segment elevation, we don't like. Notice here you have your P wave, then you have your Q, then you have your R, then all of a sudden, remember your S over here, it's dipped, and then it goes straight, and then you have your bump. It's not. This is elevated. Your isoelectric line would be right here, and it's way above the isoelectric line. So this is ST elevation. You see this patient having chest pain, all that good stuff. It's representing injury to the cardiac muscle. Another thing you need to be looking for as well, ST segment depression. They may have either or. ST segment depression, this is where there's your P, Q, R, and then ST, notice, it's supposed to be on the isoelectric line nice and straight. It went way below the isoelectric line, and then you have your T wave. So this is ST segment depression. This represents ischemia. Next, another thing you may see that you also need to be looking for is those hyperacute T waves. This is different. Remember in the hyperkalemia videos we talked about tall T waves for hyperkalemia? Well, this is a little bit different. These waves are going to be tall. They're not going to be pointed like how in hyperkalemia. They're going to be nice and round and tall. So if you see this and the patient's complaining of chest pain, you got some ischemia going on. Not good, because that's your T wave. And there, so P, Q, R, S, and then nice hyperacute T wave. Or you need to be looking for some inverted T waves. Notice our T wave is absolutely flipped underneath the isoelectric line. So if you see that, patient having chest pain, ischemia, not good. Then you may have a pathological Q wave. You really got to pay attention to this. Q wave, it's just a little area, and you need to take a lot of practice in looking at this. But this could represent a current or prior, an old infarction. And I want to show you a normal one. Here where the arrow is pointing, that is a normal Q wave. It just barely dips below the isoelectric line. Now you can have different variations of this pathological Q wave. Notice right here, you don't have a dip at all. The Q wave, it's literally absent. It's not even there. So that could be one. Or your Q wave can go way below that isoelectric line, even and then just be really long, and then you have your R and then your ST segment. So those, if you see those, that could represent a current or an old infarction. Okay, so that was part 1 of myocardial infarction. Now be sure to check out part 2 to learn about the nursing interventions and medications used to treat this condition. And thank you so much for watching, and please consider subscribing to this YouTube channel.